you, everyone. First, thank you for inviting me here. It's both a pleasure and an honor, and thank you all for staying. I know it's very late in the afternoon and everybody's after lunch, and it's children, so I know that there is sort of a triple whammy here. But I appreciate your patience and your attention and the slides. Okay. All right. We'll go back. All right, why don't we start off talking about osteomyelitis in children. And although the initial inoculation can be something that is either a direct inoculation through the skin or can be extension from the articular region, the vast majority of osteomyelitis in children comes from a hematogenous source. So there'll be a blood-borne pathogen that will seed the bone. Now, in all age groups, by far, Staph aureus is the most common organism. And recently, it's been noted that in the community-acquired methicillin-resistant Staph aureus, there's a gene that can be coded for. It's called a gene for the Panton-Valentine leukocidin cytotoxin. It's a long word, but basically, this is a cytotoxin that has now been characterized to be involved with those lesions that are highly necrotic. So generally, all patients who do have Staph aureus will get biopsied and they send off this gene for coding to see if it is a PVL cytotoxin infection, which then portends a worse prognosis, and the child has much more careful attention. Well, everyone gets careful attention, but this child needs to be followed out quite late. If you're under the age of 4 months, the other infectious agents can be Enterobacter and then the different group streps. But over the age of 4 and up to about 4 years of age, by far the most common is the Kingella kingae. And actually here in Israel, it's relatively prevalent in the daycare population. This is an agent that normally is housed in the back of the pharynx. However, in some children, it can be more aggressive and can spread very easily. And then, of course, H-flu is also seen in this age group. And then the patients with sickle cell disease, particularly salmonella. So where do these infections take place when they do seed the bone? The metaphysis is the site where we see the most frequent area of infection, and that's because of a few things. Number one, there's relatively sluggish flow in these sinusoids that inhabit the metaphysis, and also in this region there's a decreased number of macrophages. So there's decreased phagocytosis and the slow blood flow, and so it's an ideal place to have an organism seeding. The metaphysis, as we can see, is very vascular, and this is reflected in the imaging. On your left is a gadolinium enhanced image. A subtracted image shows us only where the contrast is going, and we can see an area of increased vascularity in the metaphysis. And similarly, on the blood pool, we can see that the agent is taken up in the metaphyses. The problem is the metaphysis can really be a very difficult area to interpret. It's confusing, particularly if there's residual red marrow. But one rule of thumb is red marrow still has more fat than muscle. And so if you compare it to the internal standard of the adjacent muscle, we can see that there's relatively fatty signal in both in the proximal metaphysis compared to the muscle. However, normal muscle also has more fat than infected muscle. So remember, if you see any fat signal in there, it's unlikely to be infected. So although the metaphyses are most frequently involved, there are areas of the body that are not in the long bones called metaphyseal equivalents. And these are particularly prevalent in the pelvis and in the apophyses and the round bones in the hand and feet. And these were initially described in a landmark article in AJR, where the author, Dr. Nixon, stated that actually any area adjacent to growth cartilage, so any growth plate immediately deep to that area is considered the metaphysis. And the pelvis is by far the area that has the most metaphyseal equivalents. So let's just take a look. This is a very young pelvis. It's an ex vivo specimen, and we can see the osseous pelvis. But remember that around the osseous pelvis, there's a large shell of cartilage. So that means that all the areas in the bone deep to this cartilage, as marked here by the X's, are all metaphyseal equivalents. And these are all areas that are very frequently seeded by blood-borne pathogens. So once the pathogen has gotten into the metaphysis, where can it go? Well, certainly it can go into the medullary cavity and extend down the shaft of bone. It can go out through the fenestrated cortex in children into a subperiosteal space, and then eventually out into the adjacent soft tissues. It can cross into the growth plate and get into the epiphysis and then out to the articular region and into the joint space. There are some areas, however, where the joint capsule is closely in approximation to the metaphysis, and so the metaphyseal infection doesn't have to go through that long path, but can go directly from the metaphysis out through the cortex and into the joint space. And this is true in the areas of the hip, the shoulder, the elbow, and the ankle. So once it's gone into the subperiosteal space, why is it there? Well, in adults, the periosteum is relatively tightly tethered, but in children, it's very loosely attached. So it's very easy to uplift the periosteum in children. However, it remains very tightly tethered at the physis or at the growth plate. It's a hypointense structure on all sequences, so it's very easily seen. And again, it's this extensive fenestration through the cortex that allows the pathogens to go from the inside of the bone to the subperiosteal location. And we can see what this looks like on this histologic slide. On the right is the periosteum. We have the cortex, and then fenestrating through the cortex are vessels, and then it goes to the fibrovascular tissue of the subperiosteal space. So it's these windows through the cortex that allow the pathogens to extend very easily. And this actually can be seen on MRIs of young children. On your left is a 2-year-old axial image through the radius, and we can see sort of this striped appearance after giving contrast. And these are actually the fenestrations where vessels are going through the cortex, and then overlying it is the thick, continuous periosteum. However, once the child has finished growing, as we can see in this 15-year-old, there no longer is an easy differentiation between the cortex, which no longer is fenestrated, and the overlying periosteum. So it looks like one thick cortex. This is an example, an axial image through the distal femur, T2 weighted image. We can see the cortex, we can see the thick periosteum, and then the infection extending from the marrow space easily out into the subperiosteal space. A 13-year-old girl presented with knee and leg pain. Radiographs were interpreted as normal. So she went on to MRI. In fact, she has quite a dramatic, extensive osteomyelitis throughout her tibia, extending into the subperiosteal space. Another patient also presented with knee pain and leg pain. We can see the femur here. There's a small area of abnormal signal on the T1 weighted sequences. And then there's a long area of subperiosteal collection. So there seems to be a mismatch on the T1 image between the abnormal marrow signal in the distal femur and the subperiosteal collection. And if we look very carefully, there's a small focus of hyperintense T1 signal in the subperiosteal space. You can see it here on this magnified view. So how do we put these two findings together? Well, if we look on the water-weighted sequence, the STIR sequence, we actually can see that the marrow is extensively involved, as is the overlying musculature. And on our axial T2 weighted images, we can see a fat fluid level in the subperiosteal space. So this has been looked at both histologically and on MRI, and the thought process is this is the sign of a very aggressive infection. When we see persistent fat signal, not only throughout the bone, but also in the subperiosteal space, it's likely that there's been such an increase in the intramedullary pressure that there essentially is ischemia to the marrow. The lipocytes die, they release their free fat globules, and these extend out both into the subperiosteal space and throughout the marrow area. And this has been proven on histology samples. When you sample that T1 weighted area that really looks quite normal, there are no cells there, it's just empty marrow space. So it's not really a diagnostic dilemma when you see fat within the subperiosteal space, but it does suggest a rather aggressive infection. Here's another example of a child who came in with extensive osteomyelitis. We can see a large subperiosteal collection. We can see T1 signal surrounding his fibula, and on the axial image we can see a fat fluid level. So again, this portends quite an aggressive infection. So once it's gone into the subperiosteal space, it very frequently will extend also into soft tissues within children. This is particularly common in the pelvis. You can see here adjacent to this ankle infection, there's a large collection within the soft tissues. Well, why is pelvic osteomyelitis such a dilemma? Well, as we said, there are so many metaphyseal equivalents in the pelvis. So the vast majority of metaphyseal equivalent infections occur in the pelvis, and many of these will extend out into the soft tissues. And unfortunately, children can't always be helpful historians, so they may come in and just be irritable. They may come in and complain of knee pain, or they may come in and complain of urinary frequency. And these are all signs of pelvic infection in children. Here we can see a child who has a right superior pubic ramus infection, but a large soft tissue component, and another child with large abscesses in the pelvis from a small sacral abnormality. This was a young child who came in. The mother complained that the child cried every time she changed the diapers. Now we have one orthopedic surgeon who doesn't believe in MRI, believe it or not, in this day and age, and so asked for a bone scan. And really on the bone scan, very little was seen. Again, the metaphyses of children already are quite hyperintense on bone scan, or take up a lot of radionuclide on bone scan, so they can mask an infection. But what was seen was that the bladder was displaced or deviated over to the left pelvis. So the child then finally underwent MRI, and we can see some large pelvic abscesses displacing the bladder over to the left. And following contrast administration, we could see that these are large drainable collections, and this child subsequently went on for drainage. How about if we go in the other direction, away from the side of the bone, and we go across the physis and into the epiphysis? Well, historically, and I think most people have been taught that in an infant there's direct communication from the metaphysis to the epiphysis. In a child or adolescence, the epiphysis acts as a barrier, and in the adult, there's continuity between the vascular supply of the shaft to the end of the bone. And diagrammatically, an infant might look like this with a lot of crossing vessels, and an MRI, if we look carefully after we give contrast of this cartilaginous epiphyseal head, we can see these vessels crossing the growth plate. In a child or adolescent, we still have some vessels adjacent to and crossing the growth plate, and this can be seen also on gadolinium-enhanced MRI. And then in the adolescent, the majority of the vessels that supply the ossified epiphysis come in from the periphery. So this is sort of the classical teaching. And that would make you look at this heel and say, well, this child came in with heel pain. We can see a little bit of lucency in the posterior calcaneus, but we know that there's a calcaneal epiphyseal growth plate, so this should not cross across into the apophysis. However, when we do the MRI, we can see in fact that there's very easy crossing through that growth plate to the calcaneal apophysis. And in fact, this is really what happens almost all the time. Although we learn that the growth plate is a barrier, I would say that delete that from your memory bank. That doesn't happen very frequently. You can see here there's crossing from the metaphysis and almost an adolescent child through the growth plate. We can see that in the proximal humerus, the distal tibia, and then in the proximal tibia. So again, the growth plate, although it may act as a relative barrier, I would put relative in really, really, really small font. All right, once it's gone across, oops, let me go back. Okay, once it's gone across the physis into the epiphysis, how can we tell that if there's no bone there, or if there's a very subtle abnormal signal? Well, as we said, extension across the growth plate is very frequent in the young children because there are a lot of vessels that traverse across from the metaphysis to the unossified epiphysis. And so what we would look for are areas of abnormal signal intensity and abnormal lack of enhancement of cartilage. And when we have infection of the unossified epiphyseal cartilage, we call that chondro-osteomyelitis. And there are some cases where there is no osteopart to it, it's really just a cartilaginous infection, in which case it would be an infectious chondritis. So here we have the shoulder of a 1-week-old. This baby was not moving her arm, and she thought initially to have had a brachial plexus palsy or a brachial plexus injury from birth, but then she developed a fever. Now, if you remember, the proximal humerus does not ossify until approximately 40 weeks of age. She was a premature infant, had no ossification, and has a large cartilaginous epiphysis that we're not seeing on radiographs. So she underwent MR imaging, and in fact, we can see that she has quite an extensive infection. She's got a focus of abnormal signal within her cartilaginous epiphysis, as well as a large associated septic arthritis. On axial imaging, we can see that infection extending out into the soft tissues. So let's take a closer look at the ossifying epiphysis and the growth cartilage, or the growth vessels that supply that. If we look at a specimen, we can see the ossification center, but then surrounding it in somewhat of a spoke wheel-like pattern, we have vascular channels. But if we look more closely at those vascular channels, those are actually not vessels themselves. This is a grouping or a conglomeration of an arterial, a venule, capillary plexus, and then some surrounding loose connective tissue. And for this reason, when you give gadolinium to a child, you will see the contrast within this spoke wheel appearance for several minutes because the contrast diffuses from the vessels out into the surrounding connective tissue, and it remains in that connective tissue for quite a while. And so you can see this normally in children, but it can also be a clue to pathology. So imagine, if you will, you give contrast. That's that little round white ball in the venule, and the contrast then diffuses out into the surrounding connective tissue. Now, if you have a hyperemic state, whether it be an infection or an arthritis, your vascular channels will be really big. You'll have a lot of contrast in there, you'll have hyperemia, and you'll get sort of this zebra-striped appearance, very prominent vessels. Now, what happens if you have a really significant infection? And now we're surrounding these areas of loose connective tissue with white cells. These white cells are numerous, they're compressing this connective tissue, and if the infection is really bad, they can almost obliterate these vascular channels. And so when you give contrast, you see no vascular channels. So if you were to look at this axial image of the proximal femur, there's a little ossification center in the middle, but the dotted arrow is pointing to an area that's completely devoid of vascular channels. This signifies a relatively significant infection, more so than the anterior part of the femur where you can see prominent vessels. So the whole proximal femoral epiphysis, or the chondroepiphysis, is infected, but the posterior part is infected more substantially than the anterior part. How can we use this to help us? Well, here we have a 10-month-old girl who had foot pain, and her radiographs were read as normal. But we know that she has a lot of cartilage in that foot, so she went on to MRI. And in fact, her MRI shows a really substantial synovitis, osteomyelitis of the talus. And then if we look at her cartilage, her unossified calcaneus, we see normal vascular channels, but notice how we're missing them in the talus. If we look at it on axial imaging, we can see that the lateral part of her talus shows normal or even hyperemic vessels, whereas medially there are no vessels at all. So everyone is worried that this medial part of the cartilaginous talus has a substantial infection. So she was treated with antibiotics and was slowly getting better, and they requested a follow-up MRI. And after treatment, we can see that although she still has some rounding soft tissue abnormalities, she's gotten her cartilage channel back, so we know that her cartilage infection is improving. This is a humerus of an infant, again, who did not move her arm, and distally we can see normal cartilage channels around the elbow, but proximally now, her abnormal signal is coalescing into a large developing intrachondral abscess. This is a substantial and severe infection. Another example of chondritis we can see in the distal femur. There are two foci that don't enhance, so these are developing intrachondral abscesses. And on the sagittal image we can see the same. So osteomyelitis can also extend into adjacent joint. This can be from an epiphyseal osteomyelitis, as in this case, or as we said, it can be from direct extension from metaphyseal foci into the hip, the proximal humerus, and the elbow. What are the complications of osteomyelitis that we worry about in children? You can have an intraosseous abscess either in the acute or in the more subacute or chronic state. This is not an uncommon abnormality, up to about a quarter of children, and we look for, as in adults, a contrast-enhanced rim around a hypointense center, as in this acute case of distal femoral osteomyelitis. This is a child who had knee pain for 6 months, and MRI shows that there's an intraosseous subacute abscess or a Brody abscess. Notice again it's crossing the growth plate. The other dreaded complication of osteomyelitis is growth arrest, and this will account for a pretty substantial portion of children who do have growth arrest. It causes growth arrest by either direct destruction of the physis from a metaphyseal focus, or it can cause ischemia of the blood vessels that supply the physis and thus cause growth arrest. And this is really a common mechanism, particularly for meningococcemia. So here we have a premature infant who has staph sepsis. Again, we don't have a cartilaginous epiphysis, but that was involved with the infection. We can see periosteal new bone formation along the distal femur. Child was treated, and 2 years later, this is what the knee joint looks like. So there's been a substantial growth arrest. The growth plate is abnormal. We can see on the lateral view that there's anterior angulation. If we look at the MRI taken at 2 years of age, we can see again the very abnormal appearance of the growth plate. The proximal tibia looks normal, but the distal femur is dramatically abnormal with no normal physeal cartilage. And this unfortunate boy had meningococcemia as a toddler, underwent amputations, and if we look carefully, he's got coned epiphyses, which are signs of growth abnormality in the center of the growth plate, and underwent numerous amputations. This child had hip pain. The child was 3 years old, came in and they were concerned for osteomyelitis, so they requested an MRI. And in the MRI, all we saw was a small amount of joint fluid, and after giving cartilage, no substantial synovial hypertrophy. The clinicians thought this was more consistent with toxic synovitis, and the child was sent home. The child comes back 2 weeks later, and now we can see that there's a substantial amount of enhancing synovium, a lot of synovial hypertrophy. We've got abnormal marrow signal in areas which, again, now you know are metaphyseal equivalents, adjacent to the growth cartilage of the triradiate cartilage. We've got abnormal signal in the proximal femoral head, and we've got superolateral subluxation of that proximal femur. So the child underwent treatment for the osteomyelitis, and unfortunately 1 year comes back, 1 year later comes back with a deformed proximal femoral head, very liking to Legg-Calvé-Perthes disease. So this was the initial radiograph, and unfortunately this is the follow-up radiograph. So this is one of the other complications we're concerned with in children with osteomyelitis. And then finally, some considerations when you're thinking about osteomyelitis. This is a 3-year-old boy who ran into his dog and then complained of foot pain. The orthopedist actually put him in a cast. He comes out of the cast 6 weeks later and he's unable to bear weight. So he's got what looks like disuse osteoporosis, but if we look carefully at the top of his calcaneus, we're missing some bone. Goes on to MRI, and in fact it's really his posterior talus which is dramatically affected by both intraosseous and intracartilaginous infection and associated synovial hypertrophy. So I put this in to remind us that in children up to about 50% of osteomyelitis is in the setting of prior trauma. It may be that there's trabecular injury, and so it causes even easier seeding. Children break the skin when they fall, they get bacteria under their nails, if you will, and they can seed areas of infection, or areas of trauma. This was a four-armed child who fell off the swing in a playground, comes back 3 weeks after the fall, and now you can see what looks like a permeative pattern through the radius. Underwent MR imaging, and we can see extensive osteomyelitis. However, another child also presented after a fall, and this was not too much after that first case. We saw a very subtle permeative pattern within the radius, also underwent MR imaging, had a very well-defined lesion, large soft tissue mass, and this was a Ewing sarcoma. And unfortunately, in children, Ewing sarcoma can present with fever and pain and can be mistaken for osteomyelitis. This boy was at camp and started complaining of pelvic pain, so he came home. Parents brought him to the emergency room, had a radiograph, we didn't see much, underwent MR imaging, and we can see osteomyelitis of his superior pubic ramus on the left and an associated soft tissue abscess. Again, it's common in the pelvis. The bladder is uplifted to the left by enhancing soft tissue. This was osteomyelitis. However, this was osteomyelitis. However, not too far after that, this patient came in, again, left superior pubic ramus, signal abnormalities, subperiosteal elevation, bladder is elevated up and to the left, a lot of soft tissue there. We gave contrast, and in fact has a small little, what looks like an abscess, and this too is Ewing sarcoma. So remember, in children, things are not always as straightforward as they seem. 3-year-old girl came in with a swollen knee. Thought was osteomyelitis, questioned septic arthritis. Underwent MR imaging, and we see characteristic rice bodies, large posterior lymph nodes, a lot of synovial hypertrophy, and she was ultimately diagnosed with juvenile idiopathic arthritis. But notice also that her vascular channels are very prominent. So this is a hyperemic state that lets you see very prominent vascular channels. And then finally, this teenager came in complaining of toe pain, and the toe pain just wouldn't go away, so there was concern that maybe she had stubbed her toe and developed osteomyelitis. So she also underwent MR imaging, and in fact, we did see abnormal signal at the base of the proximal phalanx of her great toe. But we also saw abnormal signal at the fourth toe and abnormal signal at the second toe. So the thought was perhaps she now has multifocal osteomyelitis. So she was sent home on antibiotics, comes back 2 weeks later after antibiotics, and now complains of pain in her other foot. And in the other foot, we see diffuse areas of abnormal signal again. We've got the great toe, second toe, the fourth toe, and in this side, even the pinky. So this just didn't make a lot of sense. All of her blood cultures were negative. So finally, after extensive questioning, it turns out she had recently been diagnosed with anorexia nervosa. She wasn't dramatically thin at that point, but she was at home doing 500 sit-ups with her toes tucked under the dresser for traction, and doing this every night for the last 8 days. And so these are really all post-traumatic areas of edema-like signal. So again, I warn you, any of you who have children, don't believe a word they say. And with that, we're going to conclude. So we've looked at some changes with growth and how osteomyelitis changes with development. Remember metaphyseal, and particularly metaphyseal equivalents throughout the body. Don't forget about the cartilage, particularly in the youngest group of kids, and there are some mimics in children. So thank you.